Welcome to tonight's webinar on increasing cervical cancer screening at your practice. Thank you for taking the time to be here this evening. My name is Kim Kindler and I am with Sydney North Health Network. Firstly, the Sydney North Health Network would like to acknowledge Australia's Aboriginal people as the custodians of this land. We pay our respect and recognise their unique cultures and customs and honour their elders past, present and future, and extend that respect to any Aboriginal people attending tonight. This evening we have two presentations. We'd like to welcome Dr. Gard, Gynaecological Oncologist, Senior Staff Specialist at Royal North Shore Hospital, lecturer at Sydney University. So just a bit of a bio on Dr. Gard. Dr. Gard commenced his gynaecology training at King George V Hospital, Sydney, and has completed fellowships at the Royal Women's Hospital, the Peter MacCallum Cancer Institute in Melbourne, Vancouver General Hospital and British Columbia Cancer Agency in Vancouver. He has a special interest in familial cancers and is a member of the Australian New Zealand Gynaecological Oncology Group, the National Trials Group for Gynaecological Cancer, and is the subject matter expert for the conjoint Northern Sydney Local Health District and Sydney North Health Pathways. We also, in addition to welcoming Greg this evening, have a bit of an overview of the Cancer Institute Primary Care Screening Toolkit and some other resources that we'd like to share with you for enhancing participation rates in cervical screening. As a quick reminder why cancer screening overall is important in general practice, we know that 60% of patients surveyed reported they're most likely to pursue a screen when reminded by their GP, in preference to a reminder from a register. General practice has a unique position through the data it holds and the relationships it has with its patients to identify, engage and encourage patients who are underscreened or never screened. And lastly, reminders are the only patient intervention rated as very effective according to RACGP's Green Book, which is about putting prevention into practice. So survival rates are significantly improved when cervical cancer is detected and treated early, just like other cancers. Cervical screening in general practice, why it's important. So overall, we know that the number of new cases of cervical cancer diagnosed has decreased in recent times due to the National Cervical Screening Program, which was introduced, and also more recently due to the HPV vaccination program, which would be expected. Cervical cancer is largely preventable through HPV vaccination and the now 5-yearly screening program. Most cervical cancers occur in women who've never been screened or are not screening regularly. And GPs can help boost cervical screening rates by discussing the test with women who present for other reasons and offering self-collection to those eligible and where appropriate. Approximately 4 out of 10 eligible women are overdue for cervical screening. So just locally, participation rates in the Northern Sydney region, we don't actually have accurate rates to report because of the changes to the program in the last 4 years, which went, as most of you would know, from 2-yearly screening to 5-yearly. However, the National Cancer Screening Register, which stores cervical screening along with bowel screening data, is working on developing standards. So hopefully we will have some reflection of rates within the next, I guess, year and a half after 5 years. The Northern Sydney region has experienced relatively high participation rates in the context of cancer screening and overall around New South Wales up until 2017, sitting at approximately 64%. What we do know is that during 2020, screening activity or program activity was affected by the COVID-19 pandemic for various reasons. So Sydney North Health Pathways. Most health professionals will be familiar with our collaboration with the Northern Sydney Local Health District in producing Health Pathways, a clinical management and local services referral portal with around 400 live pathways. This slide on the screen now shows this cervical screening screenshot, which has just actually undergone extensive review by Dr. Gard himself and our Sydney North and Local Health District Health Pathways team. So you can access the pathways via the table of contents at the top, the search bar. Oh, sorry, the search bar at the top, or via the table of contents down the left-hand side. Additionally, a suite of other gynecological oncology pathways has been developed last year with Dr. Gard as the subject matter expert and our Health Pathways team. These include cervical cancer, endometrial cancer, ovarian cancer, and there is a pathway for gynecological oncology review. We urge you to visit and use Health Pathways. The username and pathway is on the screen. Sorry, username and password is on the screen. Also, if any of you are interested in seeing the Health Pathways in more detail, you are welcome to have a visit from our GP liaison officer, Dr. Helen Wainwright, who is available on Tuesdays and Thursdays to come and speak to your practice teams. So the Cancer Institute Quality Improvement Toolkit. This has been developed and consolidates learnings from work done with PHNs and the Cancer Institute New South Wales, and allows for a coordinated approach to cancer screening activities. It's comprehensive, well laid out and easy to understand. It's designed to help practice staff take a self-paced, step-by-step approach to cancer screening quality improvement activities. So there are 5 modules. Each module begins with a work plan that guides you through implementing some of the module contents. Not all modules need to be completed. Modules 2 and 3 contain the bedrock for quality cancer screening activities at the practice, and you may well choose to participate in only 1 or 2 initially. Module 2 will guide you through the steps to establish clean cancer screening data and keeping it clean for the future. And this enables regular identification of underscreened patients and to also monitor your patients' cancer screening participation rates and systematically reminders that will follow for the future. Module 3 provides an example of a cancer screening workflow that assists with improving family history taking, building a system for cancer screening reminders for all eligible patients, and integrating screening with activities that support improved patient care and business outcomes like health assessments and GP management plans. The toolkit can help form a clear direction, set goals, be inclusive of your team, and deliver increased patient engagement and participation in cancer screening in a timely manner with potentially improved patient outcomes. Accessing the toolkit may help you choose cancer screening as a quality improvement focus for your practice. And our team are always ready to help you make a start for all practitioners working in the Northern Sydney region. The Quick Start Guide is an overview of the toolkit basics and a preliminary read. It's only 3 pages. And then the 2-page readiness checklist helps practices identify where to get started for cancer screening quality improvement by identifying activities that may be undertaken. So ensuring good quality data is obviously very important, and the toolkit is considered a complete guide to everything that a practice may participate in. It refers to the multiple ways by which accurate patient information can be obtained and then used for appropriate screening and reminders. So supplementing the accuracy of that information, family history, lifestyle measures, the things that you collect about your patients, is the National Cancer Screening Register, where general practitioners and nurses via delegation may access current patient history. We'll refer to this shortly. Another option for information, and certainly part of the toolkit, is the PNCS Stand Up to Cancer Guide, where you will find detailed recipes for identifying underscreened and never screened patient cohorts, as well as webinars that feature cancer screening. And don't forget, with any of this, our team are available to help guide you. So the National Cancer Screening Register Healthcare Provider Portal. Now this is available already, and some of you will be using it. Integration with clinical software systems is available also already with Best Practice Saffron, and Medical Director is to follow. The portal allows healthcare providers to complete a range of activities, including, as you can see on the screen, access to cervical screening and bowel screening results and histories online in real time as it suits you. Additionally, more relevant for specialists is the submission of electronic forms, but also managing patient details and preferences, and of course for bowel screening, the bowel screening test kits. Okay, thank you. The National Cancer Screening Register is accessible via PRODA for providers and via delegation for nurses from the provider linked account, as you can see on the screen. So sorry, I meant to add that a provider actually must link their account before a delegation may occur. So that is really important. The Healthcare Provider Portal dashboard, as seen on the screen, displays the features that are available, which includes forms, correspondence, and participant details, with the ability to switch between views and also between cervical and bowel screening options. So correspondence allows you to view invitation and reminder letters. The participant details update all patient details, including demographic details, nominated healthcare provider, noting that participants may have different nominated healthcare providers depending on which screening program they are with, so cervical versus bowel. Healthcare providers can also update their own profile and manage delegation from users who do not have a Medicare provider number. Also, coming up in the next few months or by the end of the year, hopefully, depending, a patient portal will also be available for patients to change some of their preferences. So information about the register is available, and use on the portal, and the software, the clinical software integration, is actually available on the National Cancer Screening Register website. And that includes a user guide with detailed steps on how to actually connect to either the portal or clinical software integration. Just a little reminder about the PNCS Stand Up to Cancer Guide. Recipes for both checking your participation rates and monitoring those over time to see whether there are improvements. Similarly, recipes for checking on patients who are underscreened or never been screened for both cervical and bowel screening. Resources specific to the cervical screening program. A range of resources are available from the program website, and patient posters and brochures can also be ordered via the National Mailing and Marketing website. But I'll hasten to add these are currently under review and due for updating. However, the resources shown on the screen are still current and relevant. When it comes to self-collect, there are pathology laboratory specific information leaflets available also. There are also Indigenous resources in other languages available to download from the program website. And Family Planning New South Wales has resources to use for sexual health for patients with intellectual disability. Some other resources that may be useful for your practice waiting rooms. And finally, this is the last slide of our presentation, we urge you to encourage patients to continue reducing their cancer risk via as many lifestyle measures as they can. And that does bring us to the end of this presentation. So I would now like to hand over to you, Dr. Gard, if I may. Thank you, everybody. Thank you.
Okay, thank you, Kim. That was fantastic. I've actually certainly learned a lot. I'm going to go and register for the National Screening Register tomorrow. I haven't done that, so must do that to catch up with my patients. Firstly, I'd like to thank Robbie and Kim and Alex for inviting me to give this talk. I'd like to thank you all for being here, and a special thanks for Rebecca Roach, who's been hounding me over the last 12 months to get those guidelines done, and I think we nailed it today, so that's fantastic. I'll just try and get my talk up on the screen, and then we'll get started. I think you guys are probably aware it's just a little bit awkward in this COVID kind of world where I talk to a blank screen. Although I know you guys are there, I can't see too many of you, which is always a little disconcerting. I thought I usually start my talk with some perspective. This is a lady from Northern Sydney who actually was a very intelligent lady, very lovely lady. She very important in her own world. She had a very important job and was just too busy to get her cervical screening. She turned up to my practice with some vaginal bleeding. I put the speculum in and I saw this. In fact, turned out to be a 2B cervix cancer. She had chemoradiation treatment and got a complete response, but unfortunately 2 years later developed vertebral metastasis, and within 6 months she was dead. So although we are winning with cervical cancer, we're doing very well. I think we can always do better. And I always put this slide up to remind me what we're all about and what we're trying to do. And the bottom line is we just want to prevent cervical cancer and do the best for our patients and the women of Northern Sydney. So look, I thought we'd start with a few of the graphs just to show you how we have been doing over time. And this one is actually from the Cancer Council, and it shows the overall incidence rate of cervix cancer from 1982 on the far left right up to about 2015. So this is well before you're really looking at the impact of the vaccine. But I think the important thing is actually, if you look around 1990, 1992, it did start to come down again, started to plateau a little bit, started to come down. It was in 1991 that the actual first formal guidelines for cervical screening were developed, formulated and released by the Health Ministers Forum, and really become circulating around. And I think we can see the great success of the cervical screening program, introduced in 1991 and coming through. They were revised in 2005 and later revised in 2017, as you know, and we'll talk about some of those revisions. This one's talking about mortality from cervical cancer, and I don't know if you can actually notice, but on the y-axis, this side we're talking about sort of a rate of around about 7 per 100,000 people with the incidence, and this one we're talking about a rate of about 2 per 100,000 in mortality. So in fact, most people are cured with their cervix cancer, which is fantastic, but unfortunately this is not zero. And this is what we're working on. But again, over time, this is actually coming down. But as you can see, starting to plateau. So we can always do a little bit better. This is a very telling slide that I like to bring up. And what we've got is two lines here. You've got the incidence over time of squamous cancers and the incidence over time of adenocarcinomas on this light blue line on the below. And we've got two types of cervical cancers. We have the squames and we have the adenos. They basically the cancers are arising either side of the transformation zone within a centimetre either side. That's where they come from. And in both of them, it's the effect of the human papilloma virus on those cells, which are the precipitating factor to develop cervical cancer. And as you can see, the squames have been coming down quite impressively over time, but the adenocarcinomas really haven't moved. And so what used to be about 5% of cancers are adenocarcinomas, it's now about 25%. It really comes down to adenocarcinomas are actually harder to pick up on a pap smear, and they're harder to pick up on colposcopy. So it's just harder to screen for them. And that's why we hope that the vaccine may bring this down. And of course, the new cervical screening guidelines, where we're actually doing more intensive screening for HPV positive patients. Hopefully we can bring that down as well in the future. We really don't have the figures for that just yet. This graph tells us who actually develops cervical cancer, and cervical cancer, as you can see, is actually a disease of young women. And it's not infrequent that I'm seeing cancers. I have seen them in women in their 20s, and I think the earliest I had was about 22, 23. But it's, certainly it's a cancer of women in their 30s and beyond. And a lot of these women are still in childbearing years, and sometimes they have, not go around having their babies before they develop a cervical cancer, which of course leads to a very complicated situation. I'm not talking so much about cervical cancer today. This is just a few introductory slides. I'm more talking about HPV and screening. But keep in mind that cervical cancer still is a challenge for us. The other thing to note, of course, is that cervical cancer really just doesn't come down. The incidence stays high the whole way, and we still see women in their 80s and 90s, unfortunately, developing cervical cancer, which I think is the strength of the new cervical screening program, because if you're HPV positive at the age of 70, we keep on following you. So this slide is really just I know it's difficult to see this small writing there, but this one also lifted from the Cancer Stats is looking at international comparison. And look, we're doing pretty well. This is incidence rates where we're basically down with other developed countries. You're looking at Australia, Canada, New Zealand, the Netherlands. US is very disparate systems. The very best and the very worst, and it's a little bit higher than us. The UK is a little bit higher. Then you look, Japan actually is not so great on screening. And of course, they've got a real anti-vaxxer movement there. So we're really worried about what's going to happen in Japan. And you look at the more of the third world countries are going to be right out here with their rates of cervical cancer, being countries like India and Brazil, very high rates of cervical cancer. We're not doing too bad in Australia. So let's talk about the Pap smear, and I think a lot of people are aware of the Pap smear. The Pap smear has been around for some time, and the aim of the Pap smear is always to smear the transformation zone. And the transformation zone is it's basically the region between where the endocervical epithelium meets the ectocervical epithelium. So basically the squames and the glandular cells. And as you know, in young women, that transformation zone is usually everted out onto the cervix. So when you do a Pap smear, you can see it, you can smear it quite easily, the TZ. Some people have a very wide transformation zone with so-called ectropion or erosion. It's important then to smear a nice wide arc to sample the transformation zone. And of course, in older women, by old, it's very cruel when I say old, women basically in their late 30s, early 40s, which of course is extremely young. Those women, the transformation zone actually recedes into the canal because the squamous cells grow over the top of the adenocarcinomas, but where we still see the cancers is actually that new transformation zone in the canal of the cervix. So it is important in an older woman, and as I said, an older woman is used with older woman, it's not that old. If you can't see the TZ, you should be actually using an endocervical brush to smear within the canal. So firstly, I always like to pay homage to those who came before. As Isaac Newton says, if we have seen further is by standing on the shoulders of giants. And one of those giants was George Papanicolaou. And this is a picture of George. His first report was in 1928, and his classic treatise was in 1941, co-authored by Trout. I have included, for the first time in my talks, I've been searching for a slide of his wife, Andromache, otherwise known as Mary Papanicolaou. Really for the unique contribution of Mary Papanicolaou to cervical screening. When George and Mary Papanicolaou immigrated to the US, he was a rug salesman, and she works as a seamstress. Eventually, he got a job in a pathology lab. Now, he didn't have his own patients. He wasn't a clinician. So in fact, all the early work, developing the smear, developing the slides, developing the stains, was done on one woman. And that woman, Mary Papanicolaou, basically had a smear pretty well every day for almost 20 years. She actually never had children. She worked as a lab technician with her husband, and she was basically motivated, incredibly interested in science and the progression of science. And so, you know, as usual, the man gets all the credit, but the unique contribution of Mary Papanicolaou is incredible. The other interesting story I heard was, in fact, she used to have kind of little tea parties where smears would be taken of her friends. And in fact, the breakthrough that occurred was when one of her friends developed a cervical cancer, and they went back and looked at the slides, and they could actually see the abnormal cells on the slides when they look back at the archives. So an incredible story about how this was developed. As a side case, there was actually a guy called Rebesh in Romania who independently published, in fact, in 1926 on exfoliative cervical and vaginal cytology, completely separately. He got there 2 years earlier, probably not credited with it because he published in non-English language literature and happened to be Romanian. So it took a while for his work to get out. But in Romania, apparently they do call it the Rebesh smear in homage to Rebesh. Anyway, let's keep going. So as you guys know, in 2017, December 2017, there was a renewal of the cervical screening program. And the factors leading to the renewal were many, but some of them were the plateau in the incidences of squamous cervical cancer. We saw that with the earlier slides. There's really been a lack of significant reduction in glandular cancers since introduction of the cervical screening guidelines in 91. And we certainly know more and more, of course, about cervical cancer and HPV. And in fact, we know also a little bit more about who we should be screening and how often. Since those guidelines was commenced in 1991 and revised in 2005, we also have the introduction of liquid-based cytology. And, you know, as a product of that, we now have actually reliable HPV testing as well. So there needed to be a renewal, and of course there was. And of course that the national screening program, the national vaccination program started in 2007 for girls and 2013 for boys, and currently runs about 90%. We are one of the highest vaccinated groups in the world when it comes to the cervical cancer vaccine. You're probably aware that the original vaccine was Gardasil, and in 2018 we introduced Gardasil 9, and I'll talk about that a little bit later in the talk. I do want to pay homage as well to Harald Zerhausen. Harald Zerhausen is a German virologist who was actually the first to prove a link between HPV and cervical cancer. Quite late, actually. It was in the 1980s. And, you know, like many in the audience, perhaps, I remember the 1980s. They were good years. And it didn't seem that long ago to me. And when kids talk about new music to me, it's usually in the 90s. And, you know, anything in the 80s is kind of my time. So this is all something which has happened in our time, you know, and certainly in my time. He was working in Heidelberg at the time, and I can say he was awarded the Nobel Prize for Medicine Physiology in 2008. And I can say he's a super nice guy. He's the only Nobel laureate I've actually met. He's a truly inspiring man. I met him at the IGCS meeting in Croatia in 2008 and was so impressed. So that's Harald Zerhausen, who we can thank for proving that link between HPV and cervical cancer. The guy's in his 80s and still working. He's incredible. Source, what he showed was that the primary infection is HPV, and then there is a progression to these precancerous lesions, which we have actually been looking at with our pap smears since the 1940s, and we have an opportunity to treat that before it actually gets to cancer. Now, of course, what we've always been doing is we've been treating the footprints of the virus rather than treating the virus itself, and we've actually not been detecting the virus, we've been detecting the footprints of the virus. So it really was a sort of a quantum change when we could actually start measuring HPV reliably, and the cost of the test came down, that we could introduce it into primary screening, which is, of course, is what we've done. A few notes about HPV itself. There's over 100 types of HPV. There's over 40 different types known to inhabit the anogenital mucosa. At least 15 of these are known to be oncogenic, as in high risk, and those are the ones that we're looking at with the HPV test. The two most common are 16 and 18, which occur for over 70% of cancers. I did include this beautiful Latin quote, which is the sine qua non of cervical cancer. I'm not a Latin scholar at all, and I'm probably not saying that right. It could well be spelled something else. But anyway, I've always thought the sine qua non. And what you're looking at there is without which there is none. That is the direct translation. And that's pretty well it for HPV and cervical cancer. There's very, very few cervical cancers where you don't need to have HPV. Probably the only one that really comes to mind is adenoma malignum, which occur in women with Peutz-Jeghers syndrome, which is more of a genetic cancer. It's an extremely rare cancer. The rest, it's HPV. You don't have HPV, you're not going to get cervical cancer. The thing is that over 70% of sexually active women will become infected sometime in their lifetime. And when I see a patient with HPV, I'm always, straight up saying to them, well, look, welcome to the human race. You get HPV. That's it. Don't worry about it. You're unlucky if it persists, and that's what it comes down to, because a lot of them do go away. Now, we know that the 16 and 18 are the most common causes of cervical cancer, and we know that 6 and 11 are the most common cause of genital warts. Of course, those are the ones in the original vaccine. They're not only associated with cervical cancers, but also vulval, vaginal, and penile cancers, also anal cancers, oropharyngeal cancers, and cancers of the larynx and urogenital tract. And of course, just about all genital warts are caused by HPV, as well as this terrible thing that can happen in newborns called recurrent respiratory papillomatosis, which is usually 6 or 11, and the poor kids get basically condyloma the whole way down their airways, and it's a debilitating thing and can be frequently fatal. We know a lot about HPV, as I said. We know the structure of it. We know what the oncogenes are. We know how the oncogenes work. Basically, the E6 and E7 components of the virus bind on to the retinoblastoma gene, and they bind on to the P53 gene. These are tumor suppressor genes. So if these are knocked out, the tumor suppressor genes, which actually keep an eye on the genome, if there's errors in the genome, these genes are supposed to actually self-destruct that cell. But if those tumor suppressor genes are knocked out, then errors in the cell can go unnoted, unchecked. The cell can go on and become immortal. And of course, that is what is cervical cancer. The other important component is the L1 component, because that is the outer capsid protein. And it's important because that's what's presented to the immune system. The other thing is important is that's what's different in all the subtypes, which just makes it so difficult. And that's why we have to have an HPV vaccine for all the different subtypes. The E6 and the E7 are the same. It's the L1 that's different in all these subtypes. And in fact, what the genius of the vaccine is, it actually pulls those L1s off and makes the vaccine purely with those L1s. It's not an oncogenic vaccine. It's not a live vaccine. It's a very safe vaccine and incredibly immunogenic and incredibly effective. So we're going to talk about the vaccine at the end, but I just thought a little few introduction notes about HPV. Of course, how do girls get HPV? Look, it's almost always sexual intercourse. Of course, the women I see are horrified they could ever get it from their partner. And they really don't relax until I say, look, perhaps you could get it from your mum at birth, burn in a pool of HPV. Maybe that's what it is. And they seem to relax so much more when I say it could be from their mum rather than from their partner. I don't really understand that, but anyway, that's what they do. It gives them a way out, I guess. It's not their fault. In reality, HPV from your mother really doesn't cause too many problems other than that respiratory papillomatosis. It's the HPV that you get from sexual intercourse that causes cervical cancer. It really is very unlikely to come from undergarments or surgical gloves. What it can come from, though, is anything where you're actually putting the HPV up next to that cervix. And manual genital, oral genital, sexual intercourse can all happen. And of course, this can be both for heterosexual as well as homosexual encounters for women. So they do need to be aware that there is a need for screening. And of course, this also is important for trans men who still have a cervix. They also still need screening. Most people do clear the HPV. Most girls get it in their late teens, early 20s. You can probably guess what's happening there. I have no idea because I'm a father of 3 daughters who are in that age group. How do they get HPV? Who knows? But they're getting HPV there. Most women clear it. However, there are a significant population of women who actually have persisting HPV, and those are the ones developing cervical cancer. Most women do clear it within a short time. So the cervical screening test, which I think you're all kind of aware of, was introduced in 2017. It is primary HPV testing. If the HPV is positive for oncogenic cell types, there is reflex cytology. And of course, these are collected with liquid-based cytology. So we have the opportunity, both for quality assurance to make sure there's enough cells there, but also to do reflex testing for HPV positive women. We commence screening at the age of 25 for asymptomatic women, keeping in mind that symptomatic women can be screened earlier. Also, keeping in mind, there is this proviso for women who had a very early age of first intercourse, which is known as koitaki. Very nice word to say, but don't think what it means. But if koitaki is less than 14 years, consider the first test between 20 and 24, if that is something you listed in your history. It is 5-yearly screening for HPV negative women. And of course, with the introduction of cervical screening, we introduced this concept of self-testing, which is essentially like a low vaginal swab. That's essentially what it is. We're just trying to look at some vaginal cells and see whether they're affected by HPV. I'm going to talk a little bit more about self-testing later in the talk. Now, if you're HPV negative, as I said, repeat the cervical screening in 5 years. The special exceptions, if you're immunosuppressed, if you're on immunosuppressive drugs due to a transplant or rheumatological conditions, HIV positive, consider 3-yearly screening. There is still this in utero DES exposure where the thought is that there are increased risk of cervical abnormalities, and certainly the guidelines at the moment state we have to have yearly screening with colposcopy and a co-test, even if they've had a hysterectomy. I do think this is overkill. I'm interested to see whether that's going to change in the future. Like all of these screening guidelines, they're actually overly cautious. So this is now looking at what happens if you get HPV 16 or 18. These are the more virulent subtypes of the virus, and they're associated with most high-grade abnormalities and cervical cancers. Reflex cytology may be performed by pathology. Irrespective of whether it's negative, if you're HPV 16 or 18, you refer to colposcopy, and they'll come and see someone like myself who performs that colposcopy. Of course, if there is invasive disease, then the suspected on the smear, then the recommendation is refer to the gynae oncology service. If you see a cervix like we had on that first lady today, you know, you probably don't even need to smear that one. Just send that lady straight for biopsy. That's an obvious cervical cancer. She needs to be biopsied. I don't know if a smear is going to really help you there. She certainly should be sent, irrespective of what the smear shows. It'll probably come back inflammatory and unsatisfactory. Now, HPV other has turned out to be the interesting one. Of course, HPV other relates to all those other types of HPV that are oncogenic that are not 16 and 18. And at the moment, we don't differentiate between them because to differentiate between them probably is a more difficult test. And it's probably unnecessary because they seem to have a similar rates of progression to CIN and to cancer, which is in fact much lower than HPV 16 and 18. So if you're low grade or less and HPV other at your first smear, the recommendation is to repeat that smear in 12 months. Now, previous to February 2021, if that repeat smear in 12 months was HPV other and cytology negative or low grade or less, the recommendation was to send for colposcopy. Modeling suggests it's cost effective and in fact safe to delay again that 12-monthly interval. The risk of cervical cancer at that time is incredibly low, and the risk of actually having a significant lesion is also low. So particularly in younger women, you probably don't need to send them on after that 12 months because they may well clear it in the next 12 months. And so the recommendation is for that second smear at 2 years from February 2021, repeat it again the following year. So you're basically going out to the third screening test as in 2 years after your first index smear. There is an exception to the rule, as there's always an exception to the rule. If the patient is overdue for screening by at least 2 years prior to their initial positive HPV test, then you can send them straight for colposcopy. If they identify as being an Aboriginal or Torres Strait Islander descent, then you can send them straight for colposcopy. And if they're age 50 years or older, you're going to send them for colposcopy. I think those women are going to get colposcopy anyway over age 50 because they're not going to clear that virus. If they haven't cleared it by now, they're probably not going to clear it. So those women, the recommendation is to send them on, and we might as well screen them now. with a colposcopy. So look, this slide is a little bit messy, but it's actually incredibly complete. I won't go through it all. It will be, I think, on my slides. You can look at it later. And it's also on the Cancer Council information sheets. It's on the wiki, which I think is an incredible resource. I look it up quite frequently. You basically just type into your search engine, Wiki Cervical Screening Australia, and it'll come up with the Wikipedia, and it's a fantastic resource. This is really just talking about what we've talked about so far. Glandular lesions, all glandular lesions get referred for colposcopy. So if there is atypical endocervical cells of undetermined significance, which is the lowest sort of glandular abnormality, you send them on. And we've been particularly overly cautious with glandular lesions. As I said, it's partly because they're just hard to see in colp. They're hard to see on the smears. They really probably do need someone who knows what they're doing the colp. The other thing which is interesting is that at this point in time, if you've had a history of AIS and you get that effectively treated, even if you're HPV negative in subsequent smears, the recommendation at this point in time is to continue indefinite yearly smears for life if you've got a history of AIS. Even, and I don't understand this, but it is the case, even if you've had a hysterectomy. So that's the current guidelines. I think they'll be revised in future years. I have tried to reassure my patients it's probably unlikely that, there's going to be likely a time where you can say, look, you got 10 years after ACIS, you're HPV negative, especially if you had a hysterectomy. I can't see why you're having smears. But we obey the guidelines. That's what we do. So a little short note about women with Aboriginal and Torres Strait Island women. We do have a small population in northern Sydney. It's not as high as other areas of Sydney or New South Wales or Australia, but we do have Aboriginal women. At this point in time, there is no evidence or recommendation to screen them more frequently. As I said, if they, at that second HPV other smear, we are recommending colposcopy for these women. The really basic problem is they're not being screened, and that's why they're 3 times more likely to be diagnosed with cervical cancer. And so really what we're trying to do is just identify those women and make sure they get their Pap smears. We really want to strongly encourage the participation in the screening program. And I usually tell my patients, look, if you're part of the program, you're doing as you're told, your chance of cervical cancer is incredibly low. Women who get cervical cancer are those who don't actually have smears. This is, again, not something I necessarily want to go through in detail. I really included it so that you can look at it later, or perhaps even prompt you to go look at the wiki. What we're dealing with here is just the edge cases, the things that are a little bit rarer. So after a total hysterectomy, what does it come down to? Essentially what it comes down to is if you've got AIS, you're going to have annual co-testing definitely. Otherwise, once you've actually had a test of cure, you've had consecutive negative tests, HPV, even after treatment, you don't need to have smears after hysterectomy. And if you've never had an abnormal smear, you've had a hysterectomy, you don't need to have smears. Now, self-testing is something which came in 2017, and we really probably haven't fully evaluated the effect of self-testing and whether it's actually working. I think the only thing we can say so far is that women who are self-testing have an abnormal test. The rates of them actually following up that abnormal test is actually quite high, and that's actually very encouraging. Now, self-testing, I think clearly just makes sense. It's not going to be as good as doing a cervical smear. But look, this is looking at screening rates for women from 1996-97 to 2017. This is national screening rates for Australia. It's about 60%, and it did not move in those 20 years. It did not move. And so we've got to get that up. And really the way we're going to eliminate cervical cancer is actually getting that up. The vaccine may work down the track, but at the moment, we've got to get that up, the cervical screening. And all those things we heard about earlier, the prompts for the people to have their smears, the different registries you can look up to check if your patient's had a smear, recall of when they've had their last smear is often incorrect. And so it's nice to have that registry to check, and please smear them. If they refuse the smear because they're just not going to have a Pap smear, offer them self-testing, and hopefully they will actually go through with the self-testing. With the proviso, of course, if they have that test, they're going to have to actually we follow it up if it's positive. Now, this is actually an interesting diagram. I actually found this only half an hour ago when I was looking through just before the getting online. And this is looking at national cervical screening program participation rates per health network. Now, I used to say that based on data from Alan Ferrier, probably 20 years ago, he did a survey with Annabelle Farnsworth, and they were able to show that Northern Sydney had the highest screening rates in the world. In Australia. And as Australia's got the highest screening, one of the highest screening rates in the world, it possibly is the highest screening rate in the world. But Northern Sydney has been overtaken by both Adelaide and Perth North, which I was distraught about. So we got to get those. We've got to be a little bit. This is the time of COVID. We just have to be a little bit of state parochialism. So we've got to knock off Adelaide and Perth North from Northern Sydney, become once again the highest screening participation rate in Australia. But the bottom line is, of course, we're doing very well, but we can do better. Unfortunately, the lowest screening rates in New South Wales are in Western Sydney, and I think that's really a reflection of socioeconomic class, but also rates of immigration and where immigrants actually are, because it's well known that immigrants are far more likely to have cervical smear, have abnormal smears. And we are actually seeing quite a big South American population, particularly on the beaches, and I've seen a number of South American patients in the last 12 months with cervical cancer. So please don't forget those women. If you're seeing those women, get them smeared. Self-testing, it's for women who have never participated in the screening program, aged 30 years and over, and they're overdue by 2 years or more. As I said, it's still to be encouraged to have a smear. And in Northern Sydney, the new screening program, self-collected samples have a moderate to high sensitivity. So they've actually compared the swabs versus the cervical screening. It's actually not too bad, the sensitivity, and it's actually very high sensitivity as well, which is good. So if it's there, it's usually there. And the good thing is there are high rates of adherence to screening after follow-up, so that's encouraging. So this is the screening pathway for collection. I guess the important take homes here are when HPV is detected, that woman is going to have further investigation. If it's not detected, they can go and have their 5-yearly screening. HPV other, they come back to you for a pap smear, and then we work on that. If they're HPV 16 or 18, they come to me for a colposcopy, and I'll repeat the pap smear at that time. Of course, an unsatisfactory test, you can try repeating that test down the track. So that's the pathway for self-collection. Now I'm going to keep soldiering on with my talk. We'll probably have questions at the end. I'm sorry, I've lost my chat screen. I've also lost my time, so I don't know how we're doing. I think we're doing okay. We're going to keep plowing on with the talk. And what I thought I'd talk about is colposcopy. And as you probably noticed, I'm a buff of history, particularly medical history. And medical history is often weirder than anything that, like all history, it's weird. Humans are weird. But Hans Hinselmann was the first man to really do colposcopy. Initially, it was, he had quite a short focal length on his colposcope, but he used to have to grab the cervix with a hook and pull that cervix down to bring it down to his colposcopy. Now, as you can imagine, that hurt. And so he actually needed to then develop further colposcopes with actually a longer focal length. And of course, the focal length we now have on colposcopes means that we can actually bring them in and out to see them. I'll show you what a colposcope looks like in a moment. Now, Hans Hinselmann was an interesting guy and perhaps not a very nice man. Part of the reason why they think colposcopy took a long time to catch on was because the guy was actually, he had a temper, he was very intractable, and he would argue constantly with people who didn't agree with him. The other thing about Hans Hinselmann, he was a German at the time when it's very unpopular to be a German. The other thing about Hans Hinselmann is that he was actually implicated in Nazi war crimes during World War II. And he actually did face Nuremberg trials and was fined and banned from clinical practice for a number of years due to his involvement in particularly the Auschwitz camp. Essentially what they were doing, and even before the war, gypsy women were being sterilized by the German regime. It wasn't necessarily Hans Hinselmann, but it was doctors under his supervision. And then, of course, there was medical experiments in concentration camps. So a fairly unpopular guy, which also led for a long time for his discoveries and his tech to take a while to catch on. Papa Nicolau was Greek and adopted country America, and it was sometimes seen as a competing technology. You have a pap smear, you have a colposcopy. Now, it took a long time to be worked out. In fact, it's more of a complementary technique rather than a competing technique. Pap smear is a very good very good screening test, whereas colposcopy is a very good diagnostic test. Essentially, what colposcopy is examining the object, which is the connective tissue of the cervix of vagina, through a filter made up of the mucosa. I love that definition of colposcopy. So essentially what we're doing is it's colposcopy, where we've got a little, basically like a telescope. It's on wheels, so we move it in and out to get the focal length. Of course, Hans Hinselmann he didn't have a colposcope on wheels. He had to actually move his patients in and out. So that was very hard initially until he got a longer focal length on his colposcope. And we actually put a vinegar solution on the cervix. He tried a lot of different things and he found vinegar probably worked best. And what the vinegar did is it actually highlighted the abnormal cells. As I said, we're looking at the object, which is the stroma, through the mucosa, which is the filter. So when we look at a cervix and the cervix is pink, it's not because the mucosa is pink. The mucosa is clear. We're looking at the cervix and we're seeing it's pink because the stroma is pink. It's connective tissue and it's blood. It's going to be pink. Now, when you put the vinegar on, the 5% acetic acid, what that does is it actually highlights abnormal changes. So cells are coagulated, cells are dehydrated, cells with a high protein content will appear opaque. And you get sheets of these cells together and they'll appear like little plaques on the cervix. And what you notice is actually very sharp demarcation between normal and abnormal. That's what we do with acetic acid. Initially, colposcopy was looking at Lugol's iodine because they noted that the vagina produces glycogen. Lugol's iodine stains glycogen. Abnormal cells don't produce glycogen. So we can actually look with Lugol's iodine very clearly to see the both. I tend not to use the iodine. It probably doesn't give you as much information as the acetic acid. A lot of people will do both, and I would not criticize those people. So this is what it looks like, and I've put this slide up because it's the same cervix with the iodine negative and the aceto white. This lady's got a very, florid change with very sharp demarcation, 4-quadrant lesion, probably high grade. This one here is actually a smear of one of my own patients, and this is showing the transformation zone, and very clearly this very abnormal lesion with mosaic change, as you can see there. Mosaic change of these abnormal vessels coursing through the abnormal epithelium. It looks a bit cobblestone. That's a high-grade lesion, and was a high-grade lesion. This one here, again, high-grade lesion, showing this time that mosaic change. And of course, sometimes you get punctation as well, which is these abnormal vessels viewed end on, and you get like little dots on the cervix, and that's again a feature of high-grade dysplasia. And what I'm doing at colposcopy is I'm going to look at that area, I'm going to take a biopsy. And the biopsy we do with basically a mini tisular forceps. Look, if you've got good forceps and they're nice and sharp and you know what you're doing, it rarely hurts. It rarely hurts. I'm not saying never hurts, it sometimes does, but it rarely hurts. My party trick, which I always love, is I get the patient to breathe in as I'm taking the biopsy. I take the biopsy, and as I'm putting that biopsy into the jar, I say, "You're ready for me to take the biopsy yet?" Okay, and they go, "Oh, is it already done?" And it's already done. Okay, so it's a party trick which never gets old, but it works, and it's incredible how insensitive the cervix is to sharp pain, and you can take it without a biopsy. So treatment of dysplasia includes a cone, a loop, or the LEAP stands for loop electrosurgical excision procedure. LET stands for long loop excision of the transformation zone. It's all the same thing. It's a loop, and I'll show you a sort of a diagrammatic picture of what a loop is. It can be done under a local anesthetic or general anesthetic. Cones tend to be done under a general anesthetic, and that's when we want to treat the canal. So if someone's got a lesion in the canal, we can't see the whole TZ, we can't see the whole lesion, we're more likely to do a cone. The laser is, basically the whole thing goes up in smoke. Lasers tend to be more expensive, and they don't give you a specimen at the end of the day, which everyone likes to have a specimen. So lasers have gone a little bit out of favor. They were quite popular about 20 years ago. They're less popular now. The LEAP machines are just so simple and easy. Cryotherapy, not very much done in Australia. It has a slightly lower success rate than excisional methods like a loop. But the good thing about cryotherapy is you don't need to re-sterilize the tool. So it's actually used quite commonly in the third world countries. They basically just line up the patients. They do a culp. If the culp's abnormal, they just hit it. They don't even biopsy. They just hit it with cryotherapy. And that seems to be cost effective, because the trouble with those patients is they don't know if they're going to come back or not. So they're just going to treat them with cryotherapy. Radical diathermy is just basically just to razz up the cervix. The trouble with radical diathermy is it does actually lead a little bit more to cervical stenosis and also to pregnancy complications in a similar way to cone biopsy. So we don't tend to do radical diathermy anymore. So that's what a loop looks like. Essentially, it's like getting a little 7-iron and just chipping out the abnormal cells. Okay, so it's usually a side-to-side motion. We inject local anesthetic in the cervix. We have this little wire loop. We cut with monopolar diathermy. And it is really just like a hot knife through butter. We're cutting with energy. And the energy, they've got a pad on their leg, allowing the electrical current to come out. They've got the little wire loop, which is providing that very thin contact with the patient. Energy is proportional to the square of the inverse. It's the inverse of the square of the surface area. So a tiny little surface area, lots of energy. It just cuts like hot butter. Hot knife through butter, sorry. And then we diathermy the base of the cervix at the end to get hemostasis. The cone biopsy is more taking a cone out of the cervix, more like a bit of a cylinder, and that's done under a general anesthetic. A quick note about pregnancy. A lot of women asked about pregnancy and the effect of pregnancy, and often these are young women, and that's the important thing. And I do have a great little sort of a skit that I run every time I've got a student with me, and I go through with that student. It's hard to do because we're not in this interactive method today, but essentially what I do is I say to this student, I say, how do you actually, what is prematurity? We're saying there's an increased prematurity rate after a loop. And the student looks at me blankly and says, well, 37 weeks. And I go, great. Why 37 weeks? And then they stop. They don't know. And why 37 weeks? And look, when it comes down to it, it's just stats. Somebody had to draw the line somewhere. And it was interesting how they got to it. I won't go into it now. It might take too long. But it's basically statistics. So when we're saying there's increased risk of prematurity and cesarean section rate, what we're saying is an increased risk of delivering before 37 weeks. If you actually look at outcomes, severe perinatal mortality, delivering extremes of prematurity, admission to nursery due to prematurity, death rate from prematurity, complications of prematurity, there's no difference between a loop and not having a loop. The reason being is that babies born after 34 weeks do just fine. And 37 weeks is a bit of an artificial construct. So spontaneous labor, which is often what happens, after 34 weeks, baby's going to do fine. They won't get those problems. But it may have been they're delivering that little bit early because they had a loop. Now, the increased risk is, it's quite high, as you can see there. It's about 40% increased risk, which, it sounds a lot. It doesn't mean they've got a 40% risk of delivering early. The background rate's about 5 or 6%. They have this technique, maybe it's about 8%, but the baby's going to do just the same. So I go through that spiel every time I have a patient. And I'd have to say, hopefully most people are reassured at the end of the day, they're going to do fine. It's either they'll just baffle them with stats. Let's keep moving. Very quickly, I think I've got a little bit more time to keep going with the talk. The reason I put this slide in is, I just love the series. It's been bashed around a little bit recently, and he's a little bit non-PC, but it's a brilliant series for those who haven't seen it. But the year this came out was about, 2005, 2006. And I always thought it was ironic that the guy who was Australian of the Year when I was watching this show was actually Ian Fraser. And Ian Fraser, you may know, as being a Brisbane virologist who basically worked out how to rip those L1 components off the virus and compile them into a vaccine. And it's thanks to Ian that we have the vaccine. And in fact, his Chinese collaborator, who unfortunately passed away from a hematological malignancy before he was able to publish his results. Ian is always extremely generous, and it's very rude of me today not to actually name his collaborator. I will find that out for next time. But He's done incredible work, and we're all incredibly proud of him within the science community. So what a VLP vaccine is, it's an L1 vaccine of the natural HPV particle. It's not infectious. It's basically that capsule, and it's that capsule which is different than all the different HPV viruses. It's ripped off. It's made into these things called viralized particles. So an L1 protein goes into a capsomere, and the capsomeres go to this VLP, and the VLP is what's in the vaccine. Gardasil is not named after me, although you'd think that due to the spelling of Gard, but it's in fact to guard against SIL, which is the squamous intraepithelial lesion. Originally introduced in 2007 in Australia as a quadrivalent vaccine, 6, 11, 16, 18. It's indicated for women from 9 to 26 years, and males between 9 and 15 years, given a series of 3 injections in 0, 2, and 6 months. And there was a national program to vaccinate all women starting in 2007 and all men starting in 2013. I put this in the future 1s and 2s trials. If you want to look them up, they were reported, I think, in the New England Journal. I just really put this up because it was such an amazing acronym, and I'm sure the guy who made the acronym up is so proud of himself. It's Females United to Universally Reduce Endocervical Ectocervical Disease. That's how we get the Futures trial. And the Futures trial essentially showed it's near 100% efficacy. So essentially, I think they had 1 patient in these thousands of women who had a type-specific high-grade lesion on women who are HPV negative at the start of the trial. That's incredible, incredible, the numbers they get. It's one of the most immunogenic viruses, vaccines, and it's one of the most safest vaccines we have. It's a no-brainer to have this vaccine. It's very well tolerated. Most common adverse event was a local discomfort at the injection site. And of course, that was always with the 3rd vaccine. And you may be aware that with Gardasil 9, we're only giving the 2 vaccinations. We only need the 2. It was introduced in 2018 in our schools. And it's basically 6 and 11, which are our non-oncogenic subtypes to protect against genital warts, because no one likes genital warts. And then the next 7 most common oncogenic viral subtypes, which are 16, 18, 31, 33, 45, 52, and 58. There's proven efficacy. There's no need to repeat if you've already had the Gardasil. It's only going to give you a very marginal benefit, but it does extend the range of coverage. Now, that's McMaster's Beach, which is my new happy place. I'm happiest when I'm there with my dogs and my wife. And I think I've finished my talk. So I'm going to answer questions. Mm-hmm. Robbie, you might have to help me. I'm just onto a nothing page at the moment. I'm going to try and get to that. What I have to hit to get to that view to see questions?
Yeah,
how would you like to do it? Are we a good time for questions?
Yeah, there is a question. Yeah, Dr. Gard, sorry. There is a question, and I just, before we share that with you, I'd just like to offer to anyone else that would like to pose a question for Dr. Gard to please use the Q&A box down the bottom of the screen. So Dr. Gard, the question is, can you hear me? Oh,
yeah,
sorry.
I've just completely stuffed up my view, but that's okay. I can't see anything now.
That's okay.
I'm not sure what you guys can see of my slides, but anyway.
Oh, here. No. Oh, okay. Yes. Yeah, we're back on the beach shot. Thank you.
Okay, we'll leave it on the beach shot. That's good. I just...
yeah, very nice.
It's kind of nice, isn't it?
Oh, just a little bit, yes.
Yeah. Okay, let's keep going.
So the question is from an attendee that just missed the first part of your talk, asking, are all cervical cancers caused by HPV? And if not, what are other causes of cervical?
Yeah. As I said, the over 99% probably are. We used to say 98%, but if you look a little bit harder, it's probably over 99% of cancers you can find the HPV DNA in the cancer. The example that I usually use is the Pearce-Jaeger syndrome is associated with a very rare cancer called adenoma malignum, which is actually a very difficult cancer to diagnose, and that's not thought to be HPV related. Look, there's always something very rare. Cervical melanoma is probably not HPV related. You can get cervical melanomas, incredibly rare, but they can occur. Cervical sarcoma is probably not HPV related. Again, incredibly rare. So there's always exceptions to the rule. And as you know, in medicine, we never say never and we never say always.
Fantastic, thank you. Well, not fantastic, but you know what I mean. Yeah. There is another question. So
sure.
From Lavanya, Cervarix vaccine, is it still used?
I haven't seen or heard of Cervarix for a while. Cervarix, like the Merck one was Gardasil, and Cervarix was it AstraZeneca or was another company anyway brought out Cervarix. They're both based on Ian Fraser's work. Cervarix had slightly better cross protection to some other strains of HPV, which is why it was promoted, because it maybe covered 45 and a little bit better. Now with the Gardasil 9, there's no good reason to prescribe it because Gardasil 9 is going to give that increased protection. The thing that Cervarix didn't do is it didn't actually protect against 6 and 11. In fact, what killed Cervarix was Basil Donovan of the Sydney Sexual Health Clinic. He had this wonderful talk he used to cart around the world where he looked at the impact of Gardasil on genital warts in Sydney. And after the introduction of the vaccine, it basically dropped through the floor. And what he got to was over half the genital warts he was seeing in his clinic were in British backpackers, because British backpackers got the Cervarix vaccine and Gardasil was given to the local population. And so very clearly, side by side, with a very smaller population, with the British backpackers compared to our local population, they were actually over half of the genital warts were from that group. Of course, it was a very funny thing. Everyone could laugh at the POMs, which is always a fun thing to do. But of course, once Merck saw Basil's talk, they couldn't stop. They sent him all over the world. The POMs were so embarrassed they had to change. And they changed to Gardasil. So I'm not sure if you can get Cervarix anymore. I haven't seen it for a while.
Okay, thank you for that question. And a couple more, Dr. Gard. So, hi, Dr. Gard. I always worried about the HPV negative cancer. Do you recommend we do cytology for patients if they want to pay private fee to cover the 1% risk?
No. If the cervix looks normal and you do the test, you see the co-test is looking at HPV, which has over 95% sensitivity, and the cytology's got about a 60% sensitivity. So the HPV is such a better test, which is why we only need to do every 5 years. But if they're HPV positive, then we're going to do cytology yearly as a part of the co-test. And that's why those people will be screened very intensively. And even with a 60% sensitivity, within the window of opportunity going between going between CIN, high-grade dysplasia, and cancer, which is probably about 10 or 12 years, we're going to have 10 smears in that time. We'll pick it up somewhere along the line. So should an asymptomatic, wealthy, anxious woman have this done? No, I wouldn't do it. I try to talk my patients out of it. And I try to link it to other things they might like in life and look at costs of other things in their life and talk about opportunity costs. That's why, I think people who wanted to have unnecessary vaccine, the vaccine used to cost, about $170 a shot, $150 a shot, I think, wasn't it? And, a bottle of Grange is $450, and 3 unnecessary vaccines for $450. Nice pair of shoes, $450. You can do a lot with $450. So even the wealthy patients, I try to explain that to them.
My goodness, that does make consultation somewhat interesting.
Oh, it's always fun. I like to talk to my patients.
Yes,
we like to have fun.
Yeah, that sounds like,
as you can probably guess. And I like to put things in perspective. And look, the perspective is really, if you're part of the program, your chances of getting cervical cancer is incredibly low.
Yes, yeah, that's a fantastic sort of thing to emphasise. So, Dr. Gard, you're hot tonight because
I'm hot. It's light.
Sorry, you're not hot. The questions are coming in.
Okay, well, I'm glad there's lots of questions.
Yeah. So another one, for self-collection, they send the swab to Melbourne and it takes about 3 to 4 weeks for a result to come back. Is there any plan for lab to be
I
established?
thought DHM were doing self-collection swabs, because I've seen data from DHM looking at their population. I could be wrong on that, but I thought it was. I know that initially they were keen for all to be processed within the one lab for both quality assurance, but more actually, I think they just wanted to know the results, because this was something new to do, and that's why it's all going down to VCS, which is the Victorian Cytology Service. So that could be the reason why it's all going down to Victoria, and it's because it's a new program. They wanted to get the quality assurance right, and they wanted to get the data right, because I think the data is the most interesting. But I did see some studies from DHM looking at where they've done both a self-collected swab and a regular swab. So I guess that might have just been as part of their study. So I'm not sure whether it's being done locally. We might have to ask Annabelle Farnsworth about that one next time we see Annabelle.
Well, actually, Dr. Gard, one of our GPs has responded with Douglas Hanley Moir are definitely doing self-collection now.
Yeah, I thought they were, yeah.
And I can add that on their website, they do actually have their own version of a self-collect fact sheet information, you know, for the patient.
Fantastic, yeah.
I'm not sure how different it is to...
Look, DHM's a great lab, yeah.
Yeah,
so they do good things. They're good people, and they participate in research and quality assurance and things. It's not an ad for DHM. I'm not getting paid by DHM. Lots of good labs out there. Lavity, good lab. Farms, good labs.
Yeah.
All my friends.
Yeah, thank you. They would have to be, wouldn't they?
It's a very small world, gynae oncology, so we all know each other very well. You know, so.
Yeah, that's fantastic.
Can't say anything bad against my friends.
Yeah. Another question, Dr. Gard, is it worthwhile to recommend Gardasil to over 45-year-old males with genital warts?
Too late for the guys with genital warts, because it's not going to actually increase. It's not going to fix the warts, because they've already got them, and that's not the way the vaccine works. The vaccine will prevent future exposure, not past exposure. So that's essentially why we're vaccinating 13-year-old kids, both boys and girls, with the Gardasil 9, so they don't get genital warts when they're 45. Is it worth giving them a vaccine? Basically, it'll work the same in women and in men. And you've got to look at why, you know, what social situation they're in and what they intend to be doing. You know, if you had a previously sexually naive 45-year-old guy who is going to get a girlfriend and have sex in the future, and he's never had sex in the past, and he's never had anything, maybe it's a good idea to do, you know. Guys are less worried about getting cancers, but obviously they're the vector as well. So I haven't really been pushing it to guys, particularly older guys, who are probably less immunogenic to the young kids. I hope that answers the question. I don't, as you might guess, I don't see a lot of guys. No. So I see women. I've got 3 daughters. I've got nurses. I've got secretaries. I've got patients. 90% of my registrars are women. I have a very feminine role. It's what I do.
Well, it's food for thought, isn't it? Just in terms of patients' history.
Yeah. So I hope that answers the question. Yeah. Can Gardasil 9 be given to women over 45? I can see there's a question. Same thing. Can. It's not as effective. The problem with women over 45 is that they're not as immunogenic as they were when they're 13. But I would look at their history. I mean, if you've got a 45-year-old woman who's had, you know, she's now divorced or a partner's passed away, and she's had one partner her whole life, she's always had normal smears, and she's going to get a boyfriend and have sex and sexual relations in the future, is it worthwhile giving her a smear? Absolutely. I think I would. Sorry, if you get a vaccine, I think that's a good person to have a vaccine. I wouldn't do that. If that person, though, has had abnormal smears in the past, I wouldn't bother, because she's probably already had HPV, and she's far more likely to get in trouble with the one she's already got than the one she doesn't have. And if she's this older woman over 45 is with a guy, and that guy's the one, and she's not going to have sex with anyone else for the rest of her life, I wouldn't bother having perhaps a Gardasil 9. So I've given Gardasil to my daughters, but I haven't given Gardasil to my wife. I like to think that she's not going to have sex with anyone else but me. So, you know, maybe that's being naive, but I think I'm okay. I think I'm okay. Let's keep moving. It's getting late.
So, Dr. Gard, can you see the last question?
I can, just a sec. If a hysterectomy was done after, and they're HPV positive or HIV positive? I'm thinking that probably should be HPV positive. But if they're HIV positive, then they probably have to have a smear because they're immunocompromised. And so I would be doing that. If they were HPV positive before they had a hysterectomy, yes, you do Volt smears. And you do Volt smears yearly until you get negative both for cytology and HPV. That's called the proof of cure. And once you've got, thank you, anonymous attendee. So once you've actually got consecutive negative tests, that would be counted as a proof of cure, and they don't need to have smears again after that. But if they have persisting virus at the vaginal vault, which is common, but negative cytology, then again, HPV 16, 18, come and have a colp, HPV other, just keep going yearly, eventually have a colp. And when, of course, after they've had a colp and it's normal, we're just relying on cytology. Okay.